Well, welcome everyone to the first webinar at Scailyte for 2021. As you all know, this is the topic of why single-cell technologies are vital for endometriosis research. Endometriosis is a debilitating disease that affects 10% of women and girls of reproductive age. Currently, there is no cure, no certain cause of the disease, and no non-invasive method of diagnosing the disease, leading to a reduced quality of life for patients and a significant socio-economic burden. We are joined by Professor Dr. Michael Müller, who is a worldwide expert in endometriosis and in women's health. The complexity of the disease requires novel research approaches, including single-cell analysis. And Professor Müller started collaborating with our company, Scailyte, in a joint project 2 years ago, striving to develop non-invasive diagnostic tools and to potentially discover novel therapeutic approaches to reduce the suffering of endometriosis patients. Professor Müller is a renowned gynecologist and a gynecological oncologist and a managing director of Women's Health Clinic in the University Hospital of Bern. And let me introduce you to my co-host, who is Cinzia Donato, who is Scailyte's project leader in endometriosis. Now I give her the mic for her to introduce herself and talk a little bit more about all the endometriosis projects that we do at the company.
Yes, thank you, Kaloyan. Good afternoon, everyone. Thank you for joining us today. As our organizer has mentioned, I'm Scailyte's project leader in endometriosis. I'll give you a little bit of introduction about Scailyte. Scailyte was founded in 2017 as a spin-off of the ETH Zurich, and we are now based in Basel at the Swiss Innovation Park. Scailyte's proprietary platform called SkyVision is a neural network-based algorithm that gains clinical relevant insights from high parametric data like single-cell RNA sequencing and medical data. Scailyte has been focusing on endometriosis to discover diagnostic biomarkers with the aim of filling this big gap in the diagnostic process of young girls and women in the reproductive age. After the successful discoveries, now Scailyte is collaborating with our guest here today and Inselspital, and we are working on bringing an accurate, non-invasive and rapid diagnostic solution to the market and to position ourselves as leaders in the field of women's health diagnostics. Today, we are honored to have our collaborator and key opinion leader, Professor Müller, for this webinar. We'll be listening to Professor Müller's seminar now, which will be followed by a Q&A session. Please make sure you're muted during the whole talk, but that you already start asking some questions in the QA chat box that you can open from the bottom right side of your screen. You can also upvote questions from other members of the audience. And yeah, I'll look forward to our discussion. Professor Müller, I give you the stage now.
Okay. So can you see that one? Do you have the presentation? No.
We could before. And,
okay. I just closed it because I didn't hear anything. Okay.
Sorry.
So can you now see the presentation?
Yes.
Okay, so thank you very much. Just please stop me if there are any technical problems. So thank you very much, Cinzia, for the kind introduction. I have to deeply apologize for the delay, but as usual with techniques, we tried it. It always worked, only at the D-date it doesn't work. So now I got another way to get in the internet, so I hope it will work. So to me, it's a great pleasure and an honor to speak today and to share with you this webinar about why single-cell technologies are vital for endometriosis research, because I think that thanks to the huge knowledge and energy of Scailyte, we will be able to resolve one of the main problems in gynecology, meaning the diagnosis of endometriosis. First, I'll speak a little bit about endometriosis by itself, and then I'll go over our specific collaboration and that you see how near we are of a real diagnosis, non-invasive diagnosis of endometriosis. So endometriosis is the presence of endometrial-like tissue, endometrial glands, and endometrial stromal cells outside the uterus. 1 in 10 women have endometriosis during the prime years of their life. So that's not the way the cinemas look during COVID. That's really the number of patients having endometriosis the next time you are in a cinema. And I think these numbers, or not only I think, but everybody agrees that these numbers increases when we look at patients with infertility. About half of the infertile women have endometriosis. If we look at the specific group of women with chronic pelvic pain, this number goes up to 60%. So you see, it's a very frequent disease. It's a disease that we know since years. However, there is still in 2021 a diagnostic delay. Usually it takes about 1 year until patients go for the first consultation, and then it takes years until they have the right diagnosis. So the big question is, what are years? So this is a plus minus recent questionnaire done in different countries, and you see that in Germany and Austria it took 10 years until they had the diagnosis. Ireland and Belgium, the awareness of endometriosis is much higher than in the rest of Europe, but still it takes about 5 years there. And I'm happy that we don't have the numbers in Switzerland because they might even be higher. So you see, even nowadays, it takes a woman a long journey before she gets the right diagnosis. One of the points we learned in the last couple of years is the fact that the age at first consultation for symptoms is often younger than we think, meaning that about 2/3 of patients under the age of 30 years already had or have symptoms due to endometriosis. So endometriosis affects women during the prime years of their lives. We know certain risk factors, certain characteristics that lead or increase the risk of endometriosis, like the family history. When a woman had endometriosis, the chances that her daughters have endometriosis too is about twice as high. And if a twin has endometriosis, the chances that the other one has endometriosis is about 6 times higher. We know that low exercise might or is one of the risks for endometriosis, and increased risk to endometrial material, short menstrual cycles, heavy, longer bleeding, early menarche, or late menopause are all risk factors. If a woman had a couple of children and each time had lactation of those children, then those are protective factors. But otherwise, we don't know natural protective factors other than those two described here. So the pathogenesis of endometriosis, especially of peritoneal endometriosis, is still a huge debate. But I think that most of the people agree that retrograde menstruation, meaning that blood flows through the fallopian tube into the abdomen, is the main cause of endometriosis generally. This was a theory proposed by Sampson in 1921. However, most of the people still agree that this is probably the best possibility as the pathogenesis of endometriosis. However, we also know that about 85 to 90% of women have retrograde menstruation. So usually those cells are eliminated by macrophages that are in the abdomen. Why in 10 to 15% of cases, those endometrial cells that went through the fallopian tube then implant in the peritoneum and stick there or in other organs? That's one of the main questions we tried to solve in the last couple of years. And we know actually, and this was proposed by the Australian group, that there are different factors, meaning one are the risk factors we heard, but still a lot of patients had no disease, and the other one who developed the disease. So you might have somatic mutation. As mentioned, genetic risk factors are known but not defined exactly. And here environmental risk factors also play an important role. So all these factors together with the mutation in the endometrium by itself might be the reason why those 10 to 15% of women develop then endometriosis. One of the other points that we learned in the last couple of years is that cytokines, inflammation, is extremely important in the growing of endometriosis. For a long term, I think until 10 to 20 years ago, everybody thought that only the hormones were important for the endometriosis lesions to grow. And nowadays, we know that the cytokines, the inflammation, the intra-abdominal inflammation plays an extremely important role so that the endometriosis lesions can grow and become bigger. Here we also know, like in cancer, that if endometriosis lesions want to become bigger than 2 square millimeters, they have to develop their own vessels. So we also know that neovascularization is another important factor. So what symptoms do we have in patients with endometriosis? We have painful menstruation in about 95% of the cases. We have chronic lower abdominal pain, pain during intercourse called dyspareunia, chronic lower back pain, pain during bowel movement. And as the picture you see here, that was a woman with mainly endometriosis in the diaphragm. So the only symptom she had was shoulder pain. So you see how difficult or impossible it is to define or to find out endometriosis just looking at the symptoms or listening to the patient. What is the impact of endometriosis? And I think that's one of the most important points in endometriosis is the fact that a lot of women work nowadays, but during menstruation or during their pain, they have so much pain that actually they have absenteeism. The socio-economic costs, and I'll come to that in the next slide, are extremely high. But the quality of life of those women is decreased. They have less educational opportunities, especially fertility is a problem that means also to self-esteem and daily function. A couple of years ago, we looked with the different centers all over in Europe. So there were countries, Germany, France, Hungary, but also Israel, the US, and we looked at the costs due to endometriosis. And our study showed that the economic burden associated with endometriosis treated in referral centers is as high and similar to other chronic diseases, meaning diabetes, morbus Crohn, or rheumatoid arthritis. Those costs arise predominantly from productivity loss from the absenteeism I just mentioned before, and is also predicted and predicted by the decreased quality of life. So endometriosis is a huge problem for all the society because the costs are extremely high. Endometriosis has not only makes not only pain but also infertility. So in about 50% of infertile women, we have endometriosis, as we discussed before. However, mild endometriosis has a conception rate of about 2% to 4.5% per month, 50 to 20% monthly rate in normal couples. So you see already mild endometriosis makes decrease the monthly fertility rate. Moderate and severe endometriosis, the monthly pregnancy rate decreases to 2%. So you see the huge problem we have when we look at endometriosis and infertility. So we know that there are different fertility treatments. You might have ovarian induction and ovarian stimulation, laparoscopic removal of the lesions, intrauterine insemination, in vitro fertilization. However, if we would have an earlier diagnosis and especially better treatment also, we could reduce this subfertility. One of the other important parts is what has endometriosis to do with football. Actually, it's the same with football. People in the US think about a totally different game when you look at it there than in the UK or in Australia. So everybody speaks about football, but 3 different games according to the countries. And it's the same in endometriosis. We have different entities in endometriosis. You have peritoneal endometriosis that sticks to the wall of the abdomen. You might have ovarian endometriosis that goes to the ovary and makes ovarian cysts, or deep infiltrating endometriosis that might go into the bowel, into the bladder, or in other organs. So those are different clinical forms of endometriosis, but nowadays more and more we think that they might have all the same origin. How is endometriosis diagnosed until now? So you've seen there are a lot of different symptoms, but what we've seen are the most frequent symptoms, that dysmenorrhea, non-cyclical pelvic pain, dyspareunia, infertility or fatigue in the presence of any of the symptoms I just mentioned above, dyschezia, dysuria, hematuria, rectal bleeding, or as the example you saw before, shoulder pain. All those are symptoms. If you have a patient telling you that, and especially that the pain increases during menstruation, you have to have the suspicion of endometriosis. You then perform a clinical examination, but often you have a normal clinical examination. So the patients, what the patients tell you leads you to the diagnosis endometriosis, but you have a total normal examination. So what are the possibilities we have today? We might do a sonography, and sonography is very helpful if you have ovarian cysts, like you see here in the picture above. Or we might do MRI, but often we don't see anything. Here you see small endometriosis in the bladder. Often you have other diagnostic tests like coloscopy or cystoscopy, meaning looking in the bowel, looking in the bladder, and often you do not have any right diagnosis. So the gold standard nowadays is the laparoscopy. So it means you have to perform an operation. It is invasive, expensive, and extremely dependent on the experience of the surgeon. If we look at the accuracy of laparoscopy, we are only about 70 to 90%. So even there, if you do laparoscopy and compare to the biopsies performed during laparoscopy, it's not always endometriosis. So that's frustrating sometimes, because you do an operation and still don't have any diagnostic. What would be ideal is to have the diagnostic and then perform the laparoscopy to treat the patient. So we have no IVD until now. And here, what I just mentioned before, that was a review done a couple of years ago, where you see that the sensitivity goes up from 77% to 90%. So it's seldomly 100%. That shows you the difficulty that even having a laparoscopy might often be negative and you still don't have the right diagnosis. So what treatment options do we have nowadays? We have medical management, where the contraceptive pill is the most frequent therapy used, but it's actually, there are no countries where it is an approved indication for the treatment of endometriosis, but still that's the main we use. Progestins are another way of treatment. I think that's the most modern way of treatment nowadays, but most of those treatments have a lot of side effects. So that's often why we don't want to start a treatment without the patient being sure that she has really endometriosis. If we perform surgery, then we treat the lesions by coagulation, excision, or ablation with the laser. Nowadays, mainly excision and ablation with the laser, coagulation only in very, very small lesions. Often those patients have pain, and that's why you need also a multimodal pain therapy, about TENS, physiotherapy, complementary medicine, and nutritional counseling. However, there is no permanent cure for endometriosis. Endometriosis should be viewed as a chronic disease that requires a lifelong management plan with the objective of maximizing the use of medical treatment and avoiding repeated surgical procedures. Nowadays, it's not seldom that we have young patients of 28 or 32 years that have already been operated 10 or 15 times. And that's one of the typical one. Lea Dimpelman found that one in the internet, but you see here, that's a typical endometriosis patient, because it's a chronic disease with a high recurrence rate, and often, and that's the main problem, diagnosed too late, because diagnosis is until now always invasive. So the research on endometriosis found differences in the endometrium itself, differences in the immune systems. We did a lot of research about inflammation and cytokines, and there we saw some differences in the peritoneal fluid of patients with and without endometriosis. But again, that's something invasive, because it's the peritoneum inside the abdomen. Most studies used bulk sequencing or cultured cells. I think that if you have such a complex question, such a complex tissue, I think it would be single cell approach is needed and is mandatory. And I think that's exactly here where the huge knowledge of Scailyte might be more than helpful. And I think that's one of the most important points. Here you see a study published in last year by Wang in Nature Medicine, where actually you see the temporal transcriptome during menstrual cycle. And here in this part, these one are only the epithelial cells. So if we would look at the stromal cells too, that would be even more important. So you see the complexity of the tissue, and that shows you why it's so important. And I think, to be honest, that's the only way to find the right solution or to find the diagnosis is through single cell RNA. So thanks to the where we put then everything to the in Scailyte, and they put the network in the Skynet. And what we could do first is actually identify 7 cell types. And I think that's one of the most important steps we did at the beginning, especially those were actually the same cells also seen by Wang in his paper mentioned before. And to me, and that's, as mentioned, I'm doing research on endometriosis since more than 20 years, and it was kind of surprising to find a new group of cells, the ciliated epithelia. I think that when we look at those 7 different cells that play an extremely important role in endometriosis or in the pathogenesis of endometriosis, we will look especially at the macrophage, the ciliated epithelia, and the stromal cells, because those are more probably the cells that are the most interesting to find out or to find a solution. So as mentioned, thanks to the Skynet, and we put all the samples from patients with endometriosis and without endometriosis in the different algorithm, and did 3 trainings and validation with the different sample splits. And you see here that thanks to the learning, we were better and better, and we had a very high accuracy in prediction of endometriosis. So comparing patients with endometriosis and the controls, we had an accuracy of 86%. And you remember what I said about laparoscopy there? Sometimes you have, according to the others, only 70%. So with that single cell RNA, we were kind of even better, or at least as good as laparoscopy. Through the immunostaining done in the last couple of years, we know that the proliferative phase of the endometrium, so meaning the cell cycle before ovulation, might be even more important. And that's why we actually then did the validation for the samples from the proliferative phase only. And you see here that the accuracy was even higher at 92.6%. So those are very encouraging results, and I think that's extremely important, again, to compare with the normal laparoscopy. We then looked at the similarity of the predictive genes in the proliferative only and in the proliferative and secretory, and defined that 49 genes mainly were important looking at that. And we then performed the analysis, and during the analysis of these different pathways, it was not surprising, but very reconforting that the main difference between endometriosis patients and the controls were actually the pathways of inflammation. So as we thought, inflammation is an extremely important point in the pathogenesis of endometriosis, and here it was kind of demonstrated also. So looking at different expression genes between the control and endometriosis, we find 2 significant different DGs, again in the inflammation part, and we then wanted to look at the protein level of these DGs, and that defined those 2 specifically, and that's why we then did, and one of those is the CA125 that has been demonstrated in other series. That CA125 is an important fact, but you see that with the gene X, we kind of defined is complementary to the CA25. So if we look at CA125 at the gene X, we have a sensitivity of 39%, but I think even more important, a specificity of 94% with gene X out of 100%. So we are able kind of to say you don't have endometriosis or you have endometriosis. I think that's a very important part, and especially the complementary of this new gene helps us to define the diagnosis much better. So I'm pretty sure that thanks to the single cell RNA, as you've seen, we will be able to find out the diagnosis. And I think this is very important because that will avoid a lot of patients to go through the long journey of endometriosis. And in my last slide, I just want to thank all the patients who were agreed to participate in the different in those studies and the studies, the study nurses and all the doctors who do the tests, especially thanks Scailyte for the advances we could do and the patients from the NGS facility and liquid biobank. Thank you very much, and I'm looking forward to the Q&A.
Thank you, Professor Müller, for this nice talk and presentation. I would like again to invite the audience to write the questions in the chat or the QA box that you can find on the bottom right activity button. Meanwhile, we have already two questions which I would just read. So there is a question from Michelle asking, is there a correlation between the severity, duration of the menstrual bleeding and the disease score size?
So there are no correlation between the pain and the VA scores and the number of bleeding, actually.
Okay. Michelle, if you would like to add another question to answer to this, let me know. We have another question. If an early, reliable diagnosis can be established, where do you see the next most important steps in research?
The next step is the treatment, because nowadays we still do not have a treatment that allows patients to fight against pain and giving them the opportunity to still be fertile. So all the treatments we have nowadays would just cut the cycle and those patients cannot get pregnant anymore. So I think that would be the next step, would really be to find a solution between to find a solution that those patients can get pregnant and have their pain alleviated.
Yes, and another question was, where do you see the biggest therapeutic potential? Before onset of endometriosis in high-risk patients, or in the treatment after disease onset?
So as I'm an optimistic, I think everything together, because I think that it would be extremely important to have early diagnosis to avoid all the damages done by endometriosis. So I think if we can have an intervention early, we would avoid a lot of things going on. On the other hand, I think that the diagnosis might also help for recurrences. And if we look at the treatment, I think it would be a little bit the way it works nowadays. So meaning we would start a treatment against the symptoms. If the patient has still the symptoms, or if she doesn't get pregnant, we would do surgery and then the treatment after. So a treatment will be the same at the beginning and after.
Mm-hmm. I had also a question actually related a little bit to what you said before. You mentioned that one of the causes of endometriosis is suspected to be the retrograde menstruation. And I was wondering, is there a way to actually detect this phenomenon early enough? So
90% of women have retrograde menstruation. So that has been, that 90%? Was, yes, that were very interesting studies done in the 60s and 50s that we couldn't do again nowadays, because they injected radioactive material in the uterus. And then they looked kind of by radiography, that the radioactive material went through the fallopian tubes. But the thing is that only 10 to 15% of those patients having retrograde menstruation will then develop endometriosis. So we know that if we stop retrograde menstruation, meaning that through ovulation pill that the patient takes continuously, or through other drugs, even through IUD, progestin IUD, that if we stop the retrograde menstruation, then that's good for endometriosis. Those were also the natural protection I mentioned, lactation and pregnancy.
Interesting. We have more questions from the audience. I'm not gonna miss any of them. I'm just structuring them a little bit. Do you think the menstrual blood might be a good source to identify or find new biomarkers?
I think that might be an excellent marker, yes. An excellent way to look at, because I think somewhere it's always the same question. Is it first the egg or the hen? And I think that's the same. And I think if we analyze the menstrual blood, that some of the answers are there also.
Right. But the current sources of tissue material that has been used to find the new biomarkers, how do they space? So from endometrial biopsies to
yes. So now they are especially in the endometrial biopsies, and we look also at PBMC, but in the endometrial biopsy especially, and I think that's actually the best way to get a lot of cells that are shed naturally during menstruation. But if you want to find first a marker, then I think the best way would then be to look at the direct biopsy of the endometrium. However, I think that the menstrual fluid also is an important way to look at.
Yes. Yes. So Andres asks, is there known correlation between lifestyle factors and endometriosis?
Yes, I think that's an excellent question, and I think that's also part of the solution. So women who do not a lot of exercise have more endometriosis. So the main question is, do they don't do a lot of exercise because of the endometriosis, or the contrary? So that's the difficult point. But we know that stress is also a big factor. So if a woman has a lot of stress, her chances to get endometriosis seem also to be higher. There are some animal models where they looked at this. We know that alcohol has a direct influence. So women drink a little bit more alcohol than others have a higher risk of endometriosis. All the other nutritional factors were looked at, and we don't have a clue which might play a role. Red meat might play a role too. That's another point. And it seems that the environment plays also a role. So I think 20 years ago, we just demonstrated that dioxin has a direct effect on the endometrial tissue, and Isabel Dreyer at that time demonstrated that dioxin makes also endometriosis in a rhesus monkey. So it seemed that some environmental factors also play a role. So lifestyle and environmental factors play an extremely important role, but we still don't know which are the one important and which are less important.
Right. When you talked about red meat, they would not be good for endometriosis. You mean like the digestion of red meat would be causing more discomfort, or?
It seems like women, yes, it seems like women eating more red meat have more endometriosis.
Right. But not that directly the lives. Well, no, you mentioned it actually, that environmental factors that could play a role in endometriosis, but not in a causative way.
Environmental factors, yes, I think they might, especially alcohol, for example, too. I think that we didn't have defined exactly where or how, but I think in a causative way, it's always even more difficult to prove. Actually, at the moment, you're right, that's only an epidemiological way to look at, but dioxin might play in the causative way too, yes.
And still talking about this general description of endometriosis, you mentioned that endometriosis is a big social and economic burden. And you mentioned indeed that the absence from work, for instance, the constant stress and pain, this causes a serious damage also to our economy. What are the actual costs at the moment for diagnosing a patient, since it takes us so long? I imagine that that is also another big burden to overcome.
Exactly. So I think there it's impossible to give you a number, because that's different from country to country. I think one of the main difficulties, and I think that's in a lot of countries, the most difficulty is to find a good solution to get a laparoscopy, and to get the laparoscopy by experienced surgeon. That's one thing. The other thing, in Switzerland, a laparoscopy by itself, it depends of if you do some surgery at the same time, if the patient has to stay overnight or not. But I think usually it's about, if she stays one night, about 12 to 13,000 Swiss francs.
Wow, just for one day and one
And
operation.
and the operation, and
Yes, yeah, well,
and the diagnosis, and then you have all the blood. That's about the price. Yes.
right. And then we saw this quite strong picture of the belly of a woman that has been under surgery several times. How many times can a woman receive a laparoscopy at a certain level? Is there a maximum
No,
time?
unfortunately
Right.
not. I think that's a psychological maximum. If I would be a
Psychological
woman,
maximum.
yes, as a patient, that would be one for me. But unfortunately, a lot of women had already had more than 5 laparoscopies, but there are no maximum actually.
Mm-hmm. Yeah. There is a question from the audience regarding adenomyosis, specifically regarding the results that you showed. Would you like first to talk about the difference between adenomyosis and endometriosis?
So I think that's an excellent question. It's even difficult to know. So endometriosis would be the presence of endometrial tissue outside of the uterine cavity, and adenomyosis is endometrial tissue inside the uterine wall, so inside the muscle of the uterus. And the difficulty there is that adenomyosis also is hormonal dependent, so it grows during the cycle, and that's why those women have also a lot of pain, and sometimes similar pain than with endometriosis. Adenomyosis is also very difficult to diagnose. At the moment, we only looked at patients with endometriosis. If the patient had a defined adenomyosis only, then we excluded them. But to be honest, it might be that some patients, or a lot of women, have adenomyosis and endometriosis. So we didn't exclude those one, but we didn't look specifically at the marker in patients with adenomyosis.
There is a nice question, which is what is gene X? Well, of course, it's gene X for a reason. But would you like? I don't know. Maybe I can answer that.
I think it's better if you answer this question.
Yes. So gene X was found in our in the study. It's our blood-based biomarker, and it was found indeed through single-cell RNA sequencing of the PBMCs of these patients suspected of suffering of endometriosis. And we have analyzed the protein content of this gene X in the serum of these patients, and that's actually the biomarker that we have showed today here. For more news about gene X, keep following us, I would say. There is a very nice question from Michelle. Are there, and this was actually one of the questions I had as well, are there any good animal models for endometriosis research? Rodents probably don't qualify.
So yes, I think as mentioned before, rhesus monkey might be a good model because they have spontaneous endometriosis, but it's extremely difficult to do those experiments, and unfortunately, only monkeys are, or some monkeys are good endometriosis models, and those were used in the 80s and 90s, but I think that to my knowledge at the moment, I don't know of any of those. There are some rodents that they use to implant endometriosis, and some genetically modified rodents that they use as nude mice where they have some endometriosis. So it seems now that they work more and more on animal models. To be honest, I'm not convinced that they work as good as they should work because of the hormones, because I know there are no rodents that produce as much estrogens and progesterones as humans or monkeys. I think that's the main problem. So estrogens are usually added anyway.
Right. And what about in vitro models? Is there anything that gets as close as the complexity of the endometrium?
That's another excellent question, but difficult question. So we looked for years at the explants that were row explants. There are different immortalized cells that you might also look at, and now more and more there are interesting results looking at 3D models of endometriosis. So kind of doing the 3D models, but still I didn't work myself with a very convincing 3D model until now, but I think that will come in the next couple of years, yes.
Mm-hmm. Like organoid cultures,
Yes.
would that be? Yes. Okay. We have some more questions, and we have still 8 minutes to go. What is the risk of a false positive or a false negative diagnostic test, considering alternative diagnosis?
So I think the way we treat endometriosis now, the risk is not as big, meaning that nowadays, usually if the history of the patient, if the clinical examination or imaging tells you it might be endometriosis, we start empirical medical treatment. The difficulty is it's often kind of it needs some work to convince the patient that she uses empirical treatment if she's not sure that she has endometriosis. So I think that one of the good thing having a non-invasive diagnosis would be that we would avoid a lot of patients to take unnecessary drugs. So that would be kind of the risk of a false positive, would be that the woman would take unnecessary drugs empirically. So that's what happens already now. A false negative to me would be worse, meaning that the patient still does have pain. Nobody believes her. Their fertility gets worse, and she's undertreated. So kind of a negative diagnostic test would be undertreatment, and I think that's exactly what we try to avoid nowadays.
Right. Actually, following up, and I'll take it first. If patients take unnecessary drugs, but their symptoms dramatically improve, how unnecessary are the drugs?
That's that's exactly one of the problem in those cases, that they would not be unnecessary. But on the other hand, if she has side effects from the drug, so she improves but still has side effects, and actually she wouldn't have endometriosis, meaning a false positive, I don't think that would be very good, especially that most of the side effects we have nowadays in the treatments are depression and depressive mood. So that's the difficulty. So sometimes the symptoms get better, even dramatically better, but the side effects are bad. So if we would have an unnecessary treatment with a lot of side effects, I think it would not be as too good. But I agree that unnecessary drugs, if the symptoms dramatically improve, it's a difficult question to answer.
Are there unnecessary laparoscopies
A lot.
made?
A lot, because often you think it's endometriosis, then you perform a laparoscopy, and then you don't see anything to treat or to have diagnosis. But again, the question is, if we can tell the patient that she doesn't have endometriosis, was it really unnecessary? That's the other point of that. But often you have a negative laparoscopy, meaning you don't see any endometriosis.
Mm-hmm. Right. Going back to the, or maybe not actually, I see a lot of questions about drug treatments. Which route of administration would be the best to deliver a drug? Would a vaginally placed pill work, or would it have to be delivered at IP?
That's again, yes, it's a very interesting question. I mean that, for example, now in the progestins, we especially in Japan, they have some drugs that they apply or directly intravaginally. So it's a kind of a ring that they put in the vagina, like the new like those rings that they use for contraception, but specifically for endometriosis. And usually the best way to apply a drug is the oral way. However, if we would have a drug that you might have apply as a cream, like some hormones that we use nowadays, that would be even better. So I think the less invasive the application of the drug, the better for the patient.
Right. There is a comment followed by a question that still have side effects, I assume, from the drug treatments, unnecessary drug treatments, whether they had a test or not. And also there, I assume, a prognostic test. So I wonder if our clinical judgment will prove just as good as any diagnostic assay.
I think the clinical judgment by itself, it's impossible to really tell somebody you have endometriosis or not. And I see a lot of patients with endometriosis, and the symptoms are so different that often it's extremely difficult. You might have some seldom pains due to other reasons than endometriosis. So I think only clinically would be extremely difficult. I think the combination of clinic and non-invasive test would be the solution. To me, as a clinician, the clinic is always the most important thing. That would be kind of the indication to do the test. But the test would be kind of together with the clinic examination, the confirmation of the suspicion by the history of the patient.
Thank you for that. For the last couple of minutes, I wanted to conclude with these questions here. What is the reason, from Pascal, what is the reason that other chronic diseases such as diabetes have received so much more attention than endometriosis? Is it related to gender, or do you feel that things are starting, but do you feel that things are starting to change?
So I'm pretty sure that it's related to gender, and that's one thing. The other thing is, doing research on endometriosis since more than 20 years now, it was very difficult in the last couple of in those years to get some grants, because you don't die from endometriosis, and that's a difficult point. You have a bad quality of life, but nobody believes you because you don't see anything. You don't have cancer, so you don't die from endometriosis. You have infertility, so people think that that's your problem and not the problem of the society. And especially, unfortunately, for years and years, it had been normal that the woman has pain during endometriosis. So those are all the reasons. There are many reasons why it costs so much, and we don't know a lot about it.
Though a deep infiltrating endometriosis could be quite dangerous. Could it be life-threatening at some point?
To treat endometriosis, or?
No, deep infiltrating. Sorry, deep infiltrating endometriosis.
It's never really life-threatening, even if you have a bowel perforation, because then you treat the bowel. So nowadays, with the medicine nowadays, it's not life-threatening. On the other hand, I think that depressive mood and a decrease in quality of life is kind of life-threatening by itself.
Mm-hmm. Okay, last question. What are the efforts made in Switzerland to raise awareness at the moment?
Oh, so we have a program specific for young women. You might look at that on our homepage. And so it's kind of a small clip that young women and girls can look at and explaining endometriosis. So that's one of the main or most important program we have. We call it EndoTeach. And some people from our group go then from school to school and explain what endometriosis is. Then I think one of the difficulties in Switzerland is to have patient groups, because you have a Swiss German, a French German, and Italian German. So it's really difficult to have an awareness in all Switzerland. But I think that would be the most important next step, is to have really a strong patient organization, so that we also would have a political lobby.
Right. I would say, since we are 1 minute past 4, that we can close the round of questions. If you still have more questions, you can always contact the organizer of this webinar, and we will forward all these questions to Professor Müller, put you in touch. And yeah, Kaloyan, I'll just pass it over to you. I would like to thank you all for your attention from my side.
Yes, thank you all for coming. Thank you for staying until the end. Thank you to Professor Müller and Cinzia for helping out with the hosting and, of course, the whole presentation. So soon, be expecting the whole recording of the webinar, and I'm going to put all the speakers' accounts on LinkedIn, so you can get in touch and continue the conversation if you want. So yeah, thank you everyone for joining, and have a good evening.
Thank you very much. Bye-bye.